Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet, in our opinion, of course, and I'm one of them. So my name is Bob. I'm exactly one half of the Bob and Brad team, and today it is a real treat. We are going to be having Dr. Stuart McGill as our guest. He's, I'm going to read some of the stuff here, Professor Emeritus at the University of Waterloo. He was a professor for 30 years. He's now retired. He's still, well, now with COVID, he's not, but occasionally he's still seeing patients that fly in from all over the world. He sees some of the best athletes you can think of, and heads of state and politicians and actors. They all hear about him. He's the guy. I mean, if you have back pain, he is the guy. And we're going to talk about his book, The Back Mechanic, best book I have ever seen on back disorders and how to treat it, how to assess yourself, and how to treat yourself. So I've bought many of these copies for family members, and I will continue to do so. Just to let you know, his work, he produced over 240 peer-reviewed scientific journal papers. He's done several textbooks. I have two of them. And you can check them out. They're on still on Amazon. He's mentored over 37 graduate students. He's taught thousands of clinicians and practitioners. Again, he is the guy. He is the guy. And you can check out his website too, www.backfitpro. Just like it sounds, BackFitPro. So again, join me in welcoming Dr. McGill. Welcome, Dr. McGill. This is such an honor.
Well, thanks. Thanks very much, Bob. I've watched a number of your videos before, so I feel like we're old friends, and we should have a bowl of peanuts and a couple of beers to.
I agree, 100%. When this all clears up, we'll have to do that.
So. A couple of northern boys.
Yeah, that's right. That's right. We're tough. So. I really big fan. I mean, I just want to say this, and in my mind, you're the guy. I always look for experts in whether it's business or knee injuries or neck injuries, and with backs, you are the guy. I mean, I first see what you say, then I'll see what other people say. But you're the guy I follow. So I wanted to say that.
I have to tell you, I do the same shortcuts as well. If I need to learn something about a vehicle or whatever, I go to the guy who fixes a few thousand of them.
Yeah,
and,
exactly.
Usually they can cut to the chase.
Yeah, you can trust them. Exactly. So I'm going to just jump right into the questions, if that's okay. And so We're going to start off with how would you manage or treat someone who's got both a herniated disc and spinal stenosis? So they're flexion intolerant and extension intolerant to some extent too.
Right. I don't have a set formula for back pain or even subcategories of back pain. Every single person that I see has already been to a few clinicians and they failed. So if they were easy to fix, they would have been fixed by now. Every single patient with us starts with an assessment, a fairly thorough assessment, so I can really get some precision on the mechanism of their pains. And the first order of business, of course, is to stop the cause, if possible,
Sure.
Wind down the pain sensitivity, and then, of course, try and rebuild their body strategically to create robustness. So you use two interesting words, stenosis. Well, what is stenosis, pardon me, is usually a radiological diagnosis where a radiologist has seen a narrowing of. So that's the root word of stenosis. Well, that could be a disc bulge. It could be a older person now with some arthritic bone activity that has grown and now narrowed down either the lateral foramen or the major canal for the spinal cord. So that doesn't mean too much. I need a lot more details to fill in around stenosis. But if we were to take a person who's younger, has a disc bulge and stenosis, that just could mean they've got radiating symptoms.
Sure.
And the assessment would show what postures trigger the pain, what motions trigger the pain, what specific loads trigger the pain. Is there, because the joint may be a bit flatter now, is there a little bit of instability that is also triggering the pain? So all of these have characters and form patterns. So I'm not trying to avoid your question, but
Sure.
it all comes down to the assessment. But
I think
maybe,
what
sorry.
you're saying too is that we can't rely on the MRI, or I think you call MRs, because you might have stenosis, but then you'll find out that that really is not symptomatic.
Exactly. So, you know, an MRI is a picture, and what the MRI shows is the person's full history, historical life, really. And, you know, you can look at my face, it has wrinkles and scars and that kind of
Sure.
thing. So when you take a picture of someone's spine, is the feature that you're looking at a scar, something that was done many years ago and no longer is a pain source, or is it a fresh wound? So what's a wound and what's a scar? And this is a fundamental flaw, I think, when a radiologist reads a MR image of someone's spine without seeing the person. They don't
Sure.
know if that person is a world champion sprinter or power lifter, or they are just a couch potato, and they have no idea what their pain mechanisms are. So when
Sure.
we do an assessment, we get a context then. So then when we look at the MRI, we can say, well, we already know the pain is coming from the fourth lumbar root. As an example,
Gotcha.
your little toes are buzzing away, you've got pain in your buttocks and this kind of thing. And then we know, let's look at the lumbar fourth root and see what the mechanism is, and does it correlate one-to-one with what the assessment shows.
Got it.
So my point is the MRs can be very, very helpful. You know,
Right.
I'm just thinking of the next patient I see this afternoon. I've already seen the MRs. They have a Tarloff cyst in the fifth lumbar root. So I know that if I can create some tension on that nerve root, and that's their symptoms, and I already know they don't tolerate driving. So
Sure.
do you see, I'm getting
Yeah.
real context now to interpret that MR very specifically.
Gotcha. Well, I like to segue into your books, and the reason is because for those that don't have access to you, I feel this is the next best thing, especially the back mechanic, which is, I don't know, do you know the book Ben Hogan's 5 Lessons? It's a classic book on golf.
I do know it, actually, yes.
And the thing that always struck me about that book was how well things were explained, especially with diagrams and kind of examples. And I felt the same thing when I got to your book. This really is my favorite book to recommend on back pain. I bought it for many people. I bought it for my nephew. It explains it so well, and it kind of takes you through self-assessment. But I'd like you to maybe talk about it a little bit, and then I'd like to know if you've determined the effectiveness of that book at all. I don't know how you track that, but
okay, well, there's a couple of questions there. First of all, the book. I should just go back a little bit. I wrote my first textbook for clinicians in the year 2000. And, low back disorders is quite a heavy textbook. And I never in a million years thought I would write a book for the lay public.
Sure.
But some savvy people, and then actually a book publisher, contacted me and said, we struggled through low back disorders. It's a heavy read.
Right.
Could you make that for the lay public? And I said,
Yeah.
well, I've never written for the lay audience. I just have taught clinicians, as you know. And they said, well, you should think about this, and we want a title, Fix Your Low Back in 3 Easy Steps. And I said, well, that's not possible. I can't do it.
Sure.
And so I wrote Back Mechanic for the lay public, but Bob, it took me 5 years. And the struggle was, how can I make it truthful? You can't fix back pain in 3 easy steps. It's not possible. As you know, the book is 17 chapters, and it takes the person through a self-assessment of their pain. And based on these signs, these are different strategies to follow. But it was such a struggle to get the content valid and not tell a lie, but still make it consumable for the reader. So it was one of those things, what's the minimum information without compromising the truth? And that took me 5 years. So if I found the balance, that's good. The second part of the question, how effective is it, is a fabulous question, but I don't know how to measure that except to say, well, you could look at the reviews on Amazon, for example.
Yeah.
But I do know we were the only clinic that I've known when I was a professor at the University of Waterloo for 32 years. And I started an experimental back pain clinic there. And we followed up with every patient that we saw. I don't know any other clinic that's done this.
That's
so
amazing.
We know exactly what they came in with. We know whether they complied. We know how they were 2 years later. We know what the mechanism of their pain was, et cetera, et cetera. So I kept very exact statistics. So I can give you those statistics if you like.
Sure,
so it's not quite the book, but I can tell you how we did. Now, I'm going to preface this by saying it was an experimental clinic and we didn't get the average generic back pain person.
We got the worst of the worst.
We got the worst of the worst. We got the ones who were, some of them had lifetime compensation for their backs and whatnot. But anyway, it depends on how you ask the questions about effectiveness. So here's one category, and this was the most spectacular statistic, so I'll start with that one. If you were a patient who was told you've tried everything, you've done physical therapy, chiropractic, yoga, you've been to the surgical consults, you've seen the shrink, et cetera, the last thing for you is surgery. Now, if that's the category that you came in with, 95% of those patients were able to avoid surgery following what we suggested they do. And after 2 years, we're glad that they did. Now, that's the most impressive statistic. But if we were to subcategorize the pain mechanism into your flexion intolerant, simply that, bending forward causes your pain, 48% of those patients said they had an excellent outcome. If you were extension intolerant, believe it or not, 75%. Now, so we were more effective with the extension intolerant than the flexion intolerant. If you were both flexion and extension intolerant, in other words, you were motion intolerant, we had an 80% success rate. If you had flexion intolerance plus compression intolerance, so you sat in a chair, you grabbed the seat pan of the chair and you pulled up, and if that triggered your pain, our success went down to 33% of an excellent outcome. Then if we subcategorized your pain based on if we confirmed the pain was from the disc, 47%. If the pain was from the disc and the facets, So they're further along now.
Sure.
In the cascade of back pain, we had a 78%.
Wow.
Then we subcategorized cutting it a different way on clinical tests. If you scored a positive on this clinical test, what was our chance for success rate? So the prone, quiet lay on a table, if that took your pain away, we called that the McKenzie test. We had a 50% chance of excellent outcome. The shear instability test. So if you scored negative on the prone instability test, we had a 50% success rate. Sorry, I'm just reading these scores.
Sure.
If you were positive on that, we had a 50%, but if you had negative, we had an 80% chance.
Oh.
And then we got into, did you experience improvement after coming to the university clinic? Do you know 19% couldn't remember that they even came?
Oh, really?
So, yeah, so just to show you how bad some of them were, they were so addled on opioids.
Oh my gosh.
So we really had
really changed lives there.
Yeah, so when you take a person who was given a zero chance for success, that's the context that you need to consume those numbers. Now, I haven't been at the university for 5 years, so
sure.
I've just been seeing patients here at BackFit Pro, and I haven't been as diligent with follow-up, I must admit. But
are some of your disciples still there? I mean,
no. No, well, with COVID, no one's anywhere, I suppose, at least here. But most of my patients, Bob, fly in.
They do.
Oh, yeah, they come from around the world.
Gotcha.
So over the past year, I've just been seeing them online, which is certainly a challenge.
Heads of state and famous athletes, and if I remember, heard you right, correct?
I've seen people from quite a number of royal families around the world, top politicians, yes, many Olympians and athletes. I don't know how they ever hear about us here in Ontario, but I think it's word of mouth that someone will.
Yep. When you were doing this book, then the back mechanic, did you you create a section and maybe go and check it with a patient to see if they understood that section? Do you know what I mean?
I think I do know what you mean. Not really. I would write a draft, and then I would have readers of the draft, and some of them were lay people, and some were clinicians.
Good, yeah.
So I used my network of friends, and also I can't spell, never have been able to. So, of course, to have a few of those sorts of English skill readers.
Well, again, I want to give one more boost to the book, and we'll mention it later again, though. It's just really well worth your time if you have back pain to check this out, because you can self-assess and then self-treat, basically. And then at that point, you can maybe go on to find a practitioner that could help you, maybe in addition. But
yeah, I think it's important to always be savvy. And that allows you to really have a target with the clinician, and it helps them to work with the pained person a lot more efficiently. So, it's like taking your car into the auto shop. If the guy says, "Oh, yeah, exactly," yeah.
So, if they go to your website, I want to make sure I got this right. BackFit Pro, www.backfitpro, just like it sounds, .com. They can actually find people who have studied underneath you is the master clinicians, and there's the certified practitioners that they can.
Yes, we have two levels of clinicians. Those who've taken our courses, so I put all my courses online with this virus situation. The clinicians would take the courses, and there's some hands-on skill development sections with this very small enrollment with our instructors. And then they have to write an exam, and then they have a practical exam. So they bring a patient online and they have to show real skill in assessment and in coaching the person out of pain.
Gotcha.
And then if they pass that, they are certified in our method, but I still haven't seen them at this point. Then
Sure.
we have the highest level, which is what we call our master clinicians, and I've worked with them personally and made sure that if I send them 20 challenging and different back pain patients, they will get 18 of those 20 better. That's what I want out of them.
There's some pressure there.
Well, there is, but my name's on it. Sure. And I need confidence that I can send them 20 back pain patients and they are going to have the level of success. So it's not it's very difficult for me, as you can imagine, to spend that amount of time with a person and mentor them through, are they confident and competent at reading images? Can they read a person? Can you sit in front of a person and extract information out of them?
Sure.
You know, I remember having a patient who won the Poker Stars in Vegas. And I thought, well, this is fabulous. I'm not going to let this guy go. I'm going to learn as much about him as I could. And I even got out cards and I said, you know, what card do I have in my hand? And I got him to tell me what he is reading in me, my card, so that when I'm with a back pain patient and I do a small provocation, I can see it in their eyebrow. I can see it in the depth of their breath. Or, you know, with our master clinicians, I'll pluck a mustache hair and put it under a page of the phone book, and they've got to find it. Now 2 pages, now 3 pages. So when they're palpating a person's back and they get that little nerve to trigger, boom, little light, did you feel that motor unit fire? And if you can't, you're not reading the level that I need in that patient. So anyway, these are all reading people is.
You learn the tells of back pain. Poker, they call it.
Well, you know, I had one time a patient of the U.S. Homeland Security, you know, the people who control our borders. And I had one of the people who was the head of interrogation, basically. So when you get pulled back into the back room, they know how to find out if you're for real or not. And he came to BackFit Pro, which our assessment room begins in another room on leather couches with 2.5 pound density foam. They sit in front of a fireplace and the fire is going. I sit at 45 degrees off from them. It's all laid out, so I'm not confrontational. I'm sitting at the same level. And the way that we get them to speak freely and then pose very specific questions. In any case, at the end of it all, he said to me, "That was the most masterful information extraction I've ever been through. Where did you learn all of this?" And I said, well, I learned it from you guys. So to become a master clinician, the skills never end, do they? You're always,
that's exactly right. And that's what's fun about it.
And when you said at the beginning, which showed such wisdom, who's the person who knows about these things? And, you know, if you've ever run across a criminal who preys on people and you learn, what does that criminal know about finding the mark? I wish every clinician knew that, because then they would see the pain is the gun and how patients come in with PTSD because they do not know the next time the gun gets put to their head and someone slams a knife in their back, triggering horrendous acute back pain. And they are emotionally shattered. You know, we know the full, but who's the expert on that? Am I going to learn that in medical school? No,
Right.
I'm going to get a much more insight into that, talking about these sorts of things with criminals, with war vets, with, you know, just have
Exactly.
good conversations. And one thing I have learned in this life is everyone has an expertise, and they're so
Yeah.
fascinating when you get to it.
You can always learn from people, no matter who they are, and it's
Yeah.
So I know this is a bit jumping around, but I want to stay to the order of the questions. Your thoughts on traction devices or inversion tables? A lot
Yeah.
of people always have questions about these.
Yeah, yes. You know, I don't want to seem as though I'm avoiding questions, because all of these questions, there's so many ways to view them. So I'll start answering that one with science. I'm going back 25 years when we did a study on inversion tables, and there was no question that the spine lengthens with 15 minutes of hanging. And the mechanism was, as you know, the discs are hydrophilic. If we
Right.
take off the hydrostatic gravity pressure, they suck up fluid.
Sure.
And but 15 minutes after getting off the inversion table and just walking around, all that extra height and joint space and whatnot is now gone. Now, what you did do is you flushed the disc, and that's how it gets its nutrition and clears out wastes and whatnot. It's just that gravitational squeeze during the day, and the nighttime rehydrogenization of water. So that's what I think the mechanism is. It's very crude, however. So there are some people who tend to be older who will say, you know, that helps me a bit, but it gives me a bit of a headache and that
Sure.
kind of a thing. So we would never do it.
Sure.
We would much rather have the person lay on a table, and we will manually pull on their legs. Now, say they have some pelvic ring issues, an SI joint is a little bit painful. If we can externally rotate through the ankles as we're pulling, or internally rotate, one of the two can suddenly make the uh, the treatment, let me just qualify that, more effective. If they have a open fissured posterior disc bulge, and we can pull in traction, and I can do what's called a windshield wiper effect on their hands like this, and just get the pelvis to roll ever so slightly. And I've measured this on MRI. We can vacuum in some disc bulges within 15 minutes. Just with that gentle, it's not a floppy push-up, it's a rolling side to side rotational. Now, it of course doesn't work for everybody, but or I might just pick up their legs a little bit when I'm pulling in traction. And if we already have measured that there's a pain trigger associated with a femoral root, as we flex their knees, you should be able to feel, oh yeah, that right leg, they're already fighting me now with the
Sure.
tension from the femoral nerve root, which I feel right away. So the assessment just gets more precise, and now the treatment can become more precise, doing it with my hands. So that's why I would favor clinical expert precision over a inversion table any day of the week. And now I'm going to reverse the whole thing back just to finish this off. I've worked with a few masters athletes over the years, and I can think of the American powerlifter who holds the US powerlifting record for men over 70 years of age.
Oh, well,
After every single deadlift, he hangs from a bar.
he
So
does.
when you're that old, you have to create more capacity for the next lift. Otherwise, you couldn't stand the
Sure.
intensity and the cumulative effects of training. So we restore his spine through a hanging technique after every single lift. So there you go. Do you see there's no
Sure.
generic answer, but if we have details, we can get to what is best for the individual. I'm sorry, that was a bit long-winded, but
No, not at all. I know in the book too, you'll recommend for people like if they're on a walk and they find a cement bench to lean on the back of the bench with their arms straight to give a little traction to their back to if it does give them relief.
yes.
To do it throughout a walk to extend their walk maybe.
Yes, as you know, the typical central stenosis recommendation from the average clinician is to ride a bike, flex, walk with a walker. And yet we find that almost half of those people do better with what we call a park bench decompression. And if I just pull this patient table over just a little bit so
Sure.
that you can see me, what you were describing for the folks to see,
Right.
I'm going to externally rotate and just put the heels of my hands. Now this could be the bumper of a pickup truck out walking,
Sure.
could be the back of a park bench. So that's why we call it the park bench decompression. But I baby step away and then I allow my hips to approach the bench, get up on my toes, and now I post down with latissimus dorsi and my pecs, and I just now let my knees sag and take a little bit of weight. So it's slight extension with a little bit of traction. And then the person might say, you know, I have difficulty walking more than 5 minutes. So we'll say, good, go for a walk for 4 minutes. Don't trigger the symptom. Decompress as we just showed you. And they'll say, you know what, that just took my pain away. Good, go walk another 4 minutes and repeat. 5 cycles of that. For the first time in 2 years, you've now walked 20 minutes. And that will never cure their central stenosis, but it could be a very effective management strategy to extend the length of time that they're able to.
You're kind of answering the question. I know one of the future questions I have is talking about that scenario where the person has the shopping cart syndrome or whatever, and they feel better flexed forward. So over time, they flex more and more and more, and they really lose any ability to extend at all. So that's somewhat the answer, correct?
Well, it could be. It could be. There are some, I mean, ultimately, you will, I've got a family member that we're struggling with right now who's
Sure.
really reaching the end ability of, well, their body is pretty much worn out. They're
Sure.
90,
Oh,
and that strategy isn't going to work anymore.
right. Right.
And unfortunately, they have to sit. So, you
Yeah.
know, but what you do want to do is maximize the years of ability for sure.
Sure. Gotcha. 100%. 100%. Okay. Let's see where I'm at here. Oh, I've got to bring this one up or Brad will kill me. So Brad has spondylolisthesis and he loves doing knees to chest. He feels like he gets some relief from it. And I know
Yes.
you've said I really don't understand what you're saying exactly here, but it's a stretch reflex. So what is happening and why do you feel it shouldn't be done?
Well, I have had people comment about this before because in the back mechanic, I show a figure and I call them the silly stretches. And when you write a book, you can't answer everybody's back pain question.
Right.
So you try and get the biggest majority with this
Right.
particular pattern. Otherwise, I'm writing low back disorders again, and it's the
Exactly.
average person can't consume it. So that's the issue. But what I'm against here is there'll be a surgeon who says, "Oh, you've got back pain. Pull your knees to the chest before you get out of bed in the morning, and you'll be right as rain." Now, what, for everybody with back pain?
Right.
And so that's my issue. But for most people who get a little bit of relief by doing that, if they stop doing it, they'll get better. And here's what I mean. So they've been doing that for 3 or 4 years. If it worked, they
Sure.
would have got better by now, but it didn't. And usually when they pull their knees to their chest, they are creating a stretch reflex, which gives 15 to 20 minutes of analgesia. And they get this little jolly euphoria. It's very short-lived, and in another hour, they're feeling as though they have to pull their knees to their chest.
Sure.
So the usual mechanism is if they avoid that, and every time they want to pull their knees to their chest, just lay quietly on their tummy. Do that for a week, and then tell me if for the first time now, that need to pull their chests is starting to go away. In other words, that sensitivity, that nag is no longer there.
Sure.
So, even people with a disc bulge with an open fissure where flexion makes the disc bulge grow, they still get that false read, the
Sure.
neurological jolly, by pulling their knees to their chest. Now, when you get into a specific situation like spondylolisthesis, which is, for folks who don't know, the facet joints are the joints behind the spinal column and the discs, and they guide motion. But do you see, if I create micro movements like this, and then if you break this bone right here, that allows the vertebra to slip forward.
Mm-hmm.
So when you pull your knees to your chest, sometimes it resets the joint back into an unstressed position. So it's a very special condition, spondylolisthesis. So that might be the cause. It might
Sure.
be that he's listening to the stretch reflex. Generally speaking, though, with a spondy, it means it's unstable. So the joint has a shear laxity to it. If he could employ the techniques of muscular bracing, which is a tuned level of contraction, I suspect we could reduce those symptoms and his want and need. Ask him to call me.
Ah, he does a lot of core strengthening, a lot, and I think his level is actually fused. It looks like it's actually fused at that level now.
Oh, well, that may very well be.
Yeah.
Yeah.
So, but I think it is the stretch reflex, if I were to guess, that where he's getting relief from.
Yes.
It's temporary, and it's but you explained it well, so I can.
Well, here's a thought for you, Bob. What I would have him do now. You're Minnesota boys, and you know baseball.
Yeah.
So if you could ask him, can you still hear me? Okay.
Yep. Absolutely.
Stand tall. Make a V with your thumb and your finger. Slide your hands down your thighs and grab your knees hard as if you're playing shortstop in the infield. Now, every American guy knows this. Now, notice that I didn't bend my knees and I'm upright. My knees
Sure.
still stay over the middle of my foot. Now, play with the curve of the back. And if he's able to become a camel and then a cat and find that little sweet spot spinal position, and then add a little bit of stiffness by poking
Sure.
your fingers into the abdominal wall and then pushing the fingers out. Now tune the curve and then tune that amount of bracing. And then the last piece is put your shoulders into your back pocket, anti-shrug down, and now don't lift with your back, pull your hips through. It's quite a different neurology when you think about it. Pull your hips through, and then, pick up something of note, pull your hips through. And all of a sudden, a person with a spondy and that need to bend the spine to get the neurological jolly. Do what I've just said and see if all of a sudden now we've got him moving heavier things with zero pain. And then his brain says, aha, I've got it now.
Gotcha.
Okay.
And this, for anybody who like the details on that, besides they could watch it again and again, but it's also in the back mechanic. You explain how to do that.
Of course it is. And then, we'll add a little bit of, now again, American boys know basketball as well.
Yeah, right.
So, just a standing prayer, a drop step in basketball. Everyone knows how to drop step to box out an opponent. Now add a drop step, and then all of a sudden now you're playing tennis, forehand,
Sure.
backhand, pain-free. So he's eliminated the primary mechanism, not by pulling his knees to his chest, but by coming up with a strategy that has now mitigated the cause and made him stronger.
It's probably more pickleball in the United States than tennis now. That's kind of taken over. So,
yeah, it has around here as well.
oh, it does.
Isn't that interesting? Yeah, I don't play either, but
no, I don't either. So, by the way, I want to mention that you showed a model from Dynamic Disc Designs. We have that same model.
I have them all. I have probably 35 models. I don't know if you know the story, but I met Jerome Fryer, who makes these wonderful models, quite a number of years ago, and he was learning the mechanisms of back pain as we were refining them and whatnot. And he said, "Oh, I can make a model." And what a brilliant job he's done. You can see the sacroiliac joints move. You can see joint stability, and they're the most biofidelic models. They're just fabulous for teaching people and patients.
Well, since we're on that, do you mind if we talk about what you normally see as far as symptoms, as far as joint instability, and if you want to show it on the spine? This was the best demonstration I saw of this ever. I mean, it explained it to me so well. I thought it was fantastic.
Yes. When you damage a knee ligament, let me just, if I can, Bob, just let me get one of Jerome's fabulous knees, because people seem to understand knees a little bit better. So there's the anterior and posterior cruciate ligaments, and they prevent the knee from sliding back and forth. So everybody knows that when you damage a knee ligament, the joint becomes shear lax like this, and that's what triggers the pain. Rather than gliding nicely, you get these micro movements. Well, the spine experiences the same phenomenon. When you get a disc bulge or a little bit of a flattened disc, it's like letting air out of your car tire. The tire bulges on the road, and then the car's a bit sloppy driving on the road. So you add stiffness by adding air. Stiffness or turgor. So let's look at a pelvic ring and L5, L4, L3. This joint here has been it's been damaged. So it's lost its stiffness. This joint is normal and this joint is normal, but you can't see it on an MR or an X-ray. You have to physically test it. Now I'm going to apply a twisting motion. Do you see how the majority of the emotion is taking place at the joint that has been damaged? So we could do a anterior posterior shear test with our thumbs on the patient, and they say, oh yeah, there's my pain. And the character of it is, if a patient says, when I roll over in bed, I get a sharp pain, or I bend forward and flush the toilet, and I get this little movement catch. Those usually are these micro movements. And you can also see in the facet joints that Jerome has painted red, they too are taking up a majority of emotion. So back pain follows a cascade. Usually the disc will become problematic, and 2 or 3 years later, then the facets become involved. But the muscle architecture around the spine, which is a flexible rod, is absolutely brilliant. When years ago, when we were modeling all of this, we would try and come up with better designs. People would say, well, why don't we have a ball and socket joint in our spine? Or,
Sure.
why do we have these muscles? Because it forms a perfect guy wire system to allow you to move. We'd measure Middle Eastern belly dancers doing all sorts of
Sure.
fabulous things. And then we would measure a power lifter. Well, one of our people, Brian Carroll, just set the squat record of 1,306
Oh my
pounds,
God.
if you can
That's
believe
nuts.
that.
That's
But
crazy.
but can you imagine taking a stack of oranges, a flexible rod, and putting a load on it? The oranges would fly apart. And
Right.
so spines need this guy wire system. But when I mentioned earlier, if you can learn to give a little bit of stiffness by bracing the abdominal muscles, or sometimes it's pulling down the shoulders, posting down, and that adds just sufficient stiffness. And people misinterpret this. Sometimes they think, oh, they have to really brace as if they're going to be punched in the stomach. No, that's not it at all. It's tuning, just like every other joint in the body. But if you can tune out that micro movement, and then, as I said, do something like a shortstop squat, all of a sudden that micro movement is arrested. And the interesting thing about so many back injuries that involve the disc, Bill Kirkcaldy-Willis, who's passed away now, but he was such a clinical mentor of mine when I was a young fellow. You probably remember Professor
I
Kirkcaldy-Willis's
don't
book.
actually. Sorry.
He wrote a wonderful book called Managing Back Pain. And he was really the first to come up with this notion of the degenerative cascade. So a person has a normal spine, they damage the disc, and the joint becomes unstable.
Sure.
It loses its stiffness. So now it's subject to micro movements. But over time, the body's reaction to those micro movements is to grow arthritic bone. And that now, like what's happened with Brad, has stiffened and stabilized the joint. And so it's normal. It becomes injured and unstable. And then the cascade continues, and then it comes completely stable as it fuses. The joints above
Absolutely.
and below are now responsible for all of the
Right.
motion and whatnot. So, we go through those cascades. So I guess what I'm getting to is the good news is after 10 years, that joint will stiffen up.
Exactly.
Stop bending it around and delaying its eventual stabilization, or fusion, as you call it, which is nature's fusion. It starts to gristle up,
Right.
and the pain goes away. So the bad news is, well, you've lost a bit of motion, but the good news is I mean, I don't know how old you are, but I have zero pain. I used to have spine instability in my 30s. I'm in my mid 60s now. I don't have any back pain. I feel fabulous.
Isn't that amazing? Yeah,
Yeah.
I've used your, after reading your book, I used it with many patients as far as getting out of bed and tightening, because they were getting pains with the micro movements, and just had them tighten up, and the shock in their face would be really quite satisfying.
Oh,
Tighten
isn't
up and
it?
they could get out of bed without pain.
It's such, I know there's so much these days on cognitive behavioral therapy as an approach for back pain patients.
Yes.
But to me, it is just so simple to show a patient how to do something that causes them pain without pain, and then they are empowered. That
Yes.
was the best cognitive behavioral therapy going. What, you mean I'm in control of this? Yes, you are. Wow. Why didn't anyone tell me this before? I'm in control. I'm not a victim. It's a fabulous
Yeah, that actually
psychological
was one of my
strengthener.
questions for you. People present with symptom magnifications and stuff like that. But it's funny, your answer is the exact same answer I saw Robin McKenzie give. Was like, if you teach them how to take the pain away, they find out that goes away.
Yeah. Oh, we're mentioning these great names like Robin McKenzie and Bill Kirkcaldy Willis, who, again, were colleagues and mentors of mine. What a fabulous! Did you ever meet Robin
I did not
McKenzie?
meet him, no.
Oh, what a fabulous fella! But yeah, absolutely.
I met Brian Mulligan, but I haven't met.
Oh, I've met Brian as well. He's
He's a
another
character.
fabulous person. He's a character.
Yeah, he was fun. Took a couple classes from him. So, I
Yeah,
want to talk about your 3-hour assessment.
yeah.
Um, how after someone goes through your 3-hour assessment, how often are they seen, or does that vary greatly? Or I mean, because a lot of them were coming to Canada to see you.
Yeah. Well, when someone comes to see me, they usually just see me once, believe it or not. So those
Really?
statistics that I gave you of our success rate was from one visit.
Oh my gosh, that's
Yes.
amazing.
Yeah. So I don't need to treat people. I show them what causes their pain and then they treat themselves.
Wow.
Now, I need to expand that answer. When a person comes here, I invite their clinicians to come with them.
Oh, you
And some
do.
of the, yes, absolutely. So the clinician learns with the patient, first of all, how to assess whatever it was they had, because obviously they'd missed that. And then the strategies that might have a progression to them. So then here are your benchmarks. When the patient reaches this benchmark, now start thinking about this. So usually there's 7 or 8 components to the patient's, what we give them. The first of all is a thorough understanding of what their pain mechanism is. The next part is, what are the past impediments that's caused failure before? Now, if I say, well, we need you to go for a walk several times throughout the day, short walks, and then
Sure.
they say, but I can't do that. Why? Well, I don't feel safe in my neighborhood. I can't go for a walk after dark. What's the chance that that person is going to comply? It's 0.
Right.
So we have to deal with addressing all of the impediments and figure out a way to make it workable. So that's the first bit. Then the second bit is what we call the position of respite. Do you have a strategy that when you get fed up and worn out of your pain, what can you do to take it away? It might be a tummy lay, it might be sitting a certain way, it might be whatever. Then, and by the way, that can be very detailed, but so simple. We might have a person lay on their tummy. Oh, this causes extension pain. Good. Put a pillow under your hips. Ah, that took my pain away. Wait a second. Oh, no, that's not good. Turn your head the other way. Press your eyebrow. 1 pound. Oh, that took my pain away. That's sweet. Do you see what
Oh,
I mean?
sure.
Yeah, so we just nuance the heck out of it. But when someone says to me they can't find pain, unless they have something like cancer, if it's mechanical back pain, we will find a way to allow that joint to fall into a sweet spot where nothing is irritated. And then after that, we then give them movement tools. Can you get on and off the toilet, in and out of your car, brush your teeth, put on your socks in the morning, all pain-free? Tie
Sure.
your shoes, get the simple stuff right. Don't keep picking the scab all day long, just living life. And then we give them an expansion to transfer it into real life. So I think we did the first and really the only study on, is what you do in the clinic as a clinician transferring to real life? They can do their physio exercises, but are they benefiting in real life? So the next bit
Sure.
on spine hygiene is how to transfer those movement skills to real life. How do you unload, well, we're in Canada, so how do you pull a case of beer out of the back of the car? Or if
That's
you're
it
in
in
Minnesota,
Minnesota.
or if you're in Minnesota, how do you carry 2 cases of beer
Yeah, right. Very
into
good.
your fishing boat?
Very good. Very
you
good.
know so either way. And then if I was with Robin McKenzie, he would say, one bottle at a time, mate.
Very nice.
Yeah, that was typical Robin. But anyway, so then the next bit is mobility. What oh, I got to talk to you about something in just a minute. Remind me of that.
Sure.
But what things are a little bit stuck that if we could free up, your back would be better? So we've already determined from the assessment that your lack of hip mobility is causing too much
Sure.
movement responsibility in your back. If we could
Yeah.
free up your hips a little bit, or every time you rock back, your right knee's getting hung up, that goes to your hip, that goes to your pelvis, that goes to your spine. We're looking for linkage restrictions.
Sure.
Then the next part is stability. Are you optimizing the stability parts of your human linkage? Then we get into, are there neural considerations? So do you have specific issues with femoral nerve roots, sciatic nerve roots, and whatnot? And we may end up flossing them or whatever the situation requires. And then we have a talk about future strength patterns. Can you competently push? Can you competently pull? Can you competently carry? And the carry might be a bag of groceries, or it might be picking your child out of the crib, or it might be picking your grandchild up off the ground. So, we then expand those. So that is the components of what we give that person over the 3 hours. And by the way, sometimes it's less and sometimes it's more. So now, if we have an athlete where we've done all that to address their primary pain concerns, then we have to tune their body. They are elite, and their goal is a gold medal, a world gold medal.
Sure.
So then I may become part of a consulting team after that,
yes.
and we are refining. How many mechanics in the U.S. Can build a car to win Indianapolis 500 3 years in a row? Maybe 10 out of 30,000.
Right.
You get what I mean? So at that point, to really tune human performance, and I'm just there for back perspectives. Of course, they have their full team for all, but it's working with the team. So obviously those relationships are longer lasting. But no, it's just one visit.
You wanted to remind you were to tell me about something.
Oh, well, I was just going to say, I retired from the university. When I first started, computers weren't invented yet. And you remember those days.
Yes, I do,
And,
actually.
and I would answer real mail with a typewriter, and people say, what's that? But, we were out of our chair. We were always moving and working in the clinic and the lab and whatnot. And then slowly the job turned me into a computer operator, to the point where students didn't even want to come to office hours anymore. They'd say, oh, can we do this on the computer? And I say, no, how can I demonstrate something to you, or, get some palpatory skills with your hands over a computer? You've got to work at it. And so I was becoming so unhealthy being a computer operator when that's not what I signed up to do. So I retired, and now I am I'm just at the prime of my health. I've never felt better or stronger. And so 2 days a week, and I do a lot of physical work. We heat our house with wood, so I'm splitting firewood, and I live a rural life now. But I consider the 7 days a week cycle, and 2 days a week I'll strength train. Now, if it just happens to be splitting firewood, okay, that's my strength training. But if it
Sure.
isn't, I get into BackFit Pro HQ and I'll throw some weights around.
Sure.
2 days a week I do mobility. Now, when I was in my 30s, Bob, I never had to do mobility. I was
Right.
fine. I had no need for mobility. But now, I've broken my neck. I've had hip replacement, and there's a few things in my body that are getting a bit stuck that I have to work on very strategically. And then 2 days a week I do something cardio. I'll go for a bike ride
Sure.
or a ski in the winter or whatever. And then 1 day a week I do nothing. That is the day of rest. And when you look at all of the great religions that have survived for millennia, they all have one rest day.
The day of
And
rest. Yeah.
and that is so necessary for the full human health system. Let one day adapt.
Yeah,
And
I'm terrible at that.
when I live that life as I'm doing now, I feel fabulous. And I
That's
wish,
great.
some people need much more physical work and stress,
Sure.
and some need 1 or 2 days without it.
Absolutely. Absolutely. How are you doing on time, Dr. McGill?
It's 12:30. I've got a patient in an hour, so I'm fine.
Can we go another 15 minutes or
Oh,
so?
sure. As long as you're getting something out of this.
Oh, this is fantastic. I just had so many questions I want to ask. And, with our insurance system here, we can't do a 3-hour assessment, but I'm thinking we could split it up among, several treatments. Is that what you'd recommend in the United States if they were trying?
No.
Oh, what do you recommend then? Go private pay or?
I don't want to sound arrogant, Bob, and I'm sorry, this is going to sound arrogant. If it were me, there are obviously, for what we do, there's no insurance billing code. There's no billing code for a very thorough assessment to get to the cause of a person's back pain. Don't you think that's a real flaw in the system?
Absolutely.
So there are insurance companies who know us, and they will send people and pay us cash for the time spent.
We will.
And that's yes. But the rider on that, and this is the arrogance, you have to be good.
Right.
So I say to them, they don't audit. When was the last time an insurance company came and audited your practice to see if you were any good or not, or if you were any different than the physio? They don't. Isn't that astounding? That the whole medical system from top to bottom is not audited.
Right.
You don't know which surgeons are causing arachnoiditis in one patient after another. I mean, when I was at the university, I knew which surgeons you don't send a patient to because the outcome is awful. And they're still all working because there's no auditing of the system. Insurance companies have to start auditing who makes a difference. Now, most U.S. companies, and I think there's even some legislation in the U.S. that they can't send patients out of country, but some still do. And I've worked with them in the past, and they know our score. So it's very cost effective for them to send a person up. Certainly sports organizations and whatnot will send people. That's not an issue. And by the way, they are insurers. Even the team has an insurance of every player. Oh yeah. And ultimately it's the insurance. And there are ways around it in that I don't see anyone, without a physician referral. So it's that physician's referral that says this is necessary information for us to do our best work. So that's another way around it. But getting back to your relationship, you have to go to the insurance companies and say, if you're serious about the end goal of helping people, which I don't think they could care less.
Yeah,
All they care
exactly.
about is the bottom dollar.
Exactly.
But if I can, we worked with an HMO in Montana, and they learned very quickly that they could get their physios to have success with back pain with fewer visits. So at the end of the day, they weren't paying out, whatever the
Right.
statute
Exactly.
was. We will pay for 20 visits. Well, if they only needed 6, that was a cost savings.
Right.
But anyway, that's the conversation that you have to have. But we just, I charge for my time, and that's it.
Gotcha. We were talking about Robin McKenzie. I just know you call it the floppy press up. I get the sense you're not really a fan of the full press up.
No.
You feel it's too much stress.
Well, I've measured both the efficacy and the mechanics, and it's interesting. When Robin was alive, I would, he would invite me to a McKenzie meeting.
Sure.
But since he's passed, they want me to come, but I shouldn't say this, they don't want to pay a speaker's fee
Sure.
and then I'm thinking, you got to be kidding me.
Right.
But I think I've done more research on their approaches than they themselves. Now, maybe that's unfair. I would say at least up until 7 or 8 years ago, that was the way it was. Maybe they've done a lot of work since.
Sure.
So now I can answer the question. So a floppy push-up is the patient lays prone on a table and presses up. They leave their pelvis on the table and they press up their spine into extension as far as whatever is determined by the clinician. And they repeat it. And the theory is that you pump the posteriorly extruded nucleus back into the nucleus of the disc where it's supposed to be. I don't believe that. Now, you may vacuum, it's not a pumping, you may vacuum it in, but we found it's absolutely just as effective for the patient to lay prone on the table and then slowly get into an extended posture if they need to, and then maybe put 2 fists under the chin or something like that. But that prone traction that I told you about, where we will pull and then raise into extension from the leg end rather than the head end, gives you much more technique nuances to really propel that. Now, here's the things that we found. Large skeletoned people have discs that are limacon shaped, like a lima bean. Now, if they have a posterior fissure going to the edge of the limacon, they respond so much better to a McKenzie extension treatment than an ovoid disc, which is more round like this. And there, the pattern of the disc bulge is diffuse. It's not pointed at the edge of the limacon.
Gotcha.
So it's so interesting that a heavier skeleton limacon shaped disc is much more responsive to a McKenzie approach.
I think I read you also said that if they have 75% of the disc left, they respond.
Oh, Bob, you're well read. Good for you are really impressing me. You know our stuff, which is good. So if the disc has been compressed more than 75% of its original height, the chance that a McKenzie style of therapy is going to assist reduce the disc bulge is very, very slender. So you need hydraulic behavior and sufficient disc height. That's another determinant of all of this. Another determinant is the adaptations that the person's spine has already undergone because of chronic exposure. Let's take a yoga master, someone who doesn't lift heavy weights, they're slender, they like doing and practicing yoga. When they flex forward, typically the disc bulge is on the anterior part of the spine. Whereas if you take someone who trains weight training, CrossFit,
Sure.
weights like what you see here, they tend to get a disc bulge that grows when you bend forward posteriorly. See, two entirely different mechanisms. So again, the McKenzie approach would make worse a very flexible yoga type of spine, and yet it would be more therapeutic for someone who's had an injury from lifting, or they sit too much, or that kind of thing. So do you see how, again, it's nuances
Absolutely.
upon nuances?
Yes.
Yeah.
Right. No, I've had patients who did the McKenzie method without a disc problem, and I always thought that maybe it helped, get more movement in the facets. You know what I mean? Like if you had some facets that were kind of stuck and they gained a little more motion, it seemed like they did better. They had less pain.
Well, they may do, but why is the facet getting stuck?
Exactly. Why is it?
Well, I can show again Jerome's lovely models.
Sure.
Here's a model. Again, yeah, is it this one? Yeah. So all facet pairs have an angle. And
Right.
it's interesting, the ones that have open angles are the ones that have spondylitic fractures, like what Brad has. And he's probably good at playing golf and has some flexibility to his spine. But chances are he won't be playing middle linebacker.
Sure.
It's interesting. So there is a pair of closed facets on this joint, and these are much more open. Now we're going to bend into extension and watch what happens. I'm going to release the spine. This joint still has mobility. This one is stuck, and I'm going to pop it off. You can watch it. Did you see it pop
Yeah.
off?
Yeah.
Yeah. So those facets have already bound up. In other words, if they're getting stuck, you got a problem. And I wouldn't be pressing those articular surfaces into extension. I would let them settle. And anyway, you see what I mean. There's much more motion at these ones. The ones that are getting stuck, I wouldn't bind them up and grind them.
Sure. And you recommend we call it the cat camel, where you're in the
Yeah,
quarter. I mean, that one, it probably does the same thing in a safer manner.
exactly. We measured that years ago. So the safest way now, if someone doesn't have back pain, these aren't big issues.
Sure.
And people misinterpret me, say, oh, well, McGill, you're making everyone fragile. And I said, no, you didn't listen to me. I was talking about a person who has a fragile back. And our job is to get them out of back pain. If you don't have back pain, go do gymnastics and have fun.
Sure.
That's what it's all about at the end of the day. But what you're talking about, a cat camel, is a person's on their hands and knees.
Right.
Oh, I don't need to demonstrate it, but
Yeah.
they're on their hands and knees and they hump up like a camel
Yeah.
and like a cat. And to cycle the back and forth, there's very minimal compressive load. It's what we
Gotcha.
call a 3-point bend. So if I take a stick and I create a 3-point bend through it, there's no shear stress. So it's I couldn't make it into a cantilever and just stand there and do it, because that would trigger pain in a very easily triggered back.
Sure.
But the cat camel on all fours is the most spine friendly way, just to get a little gentle motion going. There's no stress to speak of in facet joints and whatnot. So that's how we converged on that. And I might say that some people, it's funny, cultures around the world. The American culture is more is better.
Right.
In this case, more is
Exactly.
not better. Only 6 or 7 cycles is sufficient to get rid of the viscosity, the feeling of tightness. Doing 20 doesn't add any more benefit. So
Sure.
just 5 or 6 cat camels, if all you want to do is to experience some gentle motion. There's some clinical guidelines for you.
Fantastic. Again, I want to be respectful of your time. I would just maybe 2 more questions.
Yeah.
Just your
Bob, I'm enjoying this. As I said,
uh,
we
I
should
love
be out
it.
on the back porch somewhere.
I mean, these are questions I've had for a long time, but what is your thoughts about piriformis syndrome or deep gluteal syndrome, as it's called? I mean, do you think it's a thing? Do you think, have you seen much of it yourself, or what are your thoughts?
Well, absolutely, it's a thing, but it has to be guided by an assessment. I will say it's tremendously over what's the word I'm looking for? It's not a diagnosis, but the term, the label, you've got piriformis syndrome, is way overused, because the majority of people with they've been told they have piriformis syndrome because they have pain over the back of the hip joint, deep in the butt cheek,
Right,
and but most of the time that will be a referred pain from their back through the sciatic nerve, because the sciatic nerve goes, as you know, right
right,
underneath piriformis. Now, having said that, there are people, no question, the root mechanism is something to do with piriformis. Now, why is that? When you look at the architecture of muscles, you know that if you have a muscle with it's a really meaty muscle with a long series of sarcomeres. In other words, the strand of the muscle is very long and they have a short tendon. That muscle can produce great length excursions. If you have another muscle architecture with a short bit of muscle and a long tendon, it can't create much
sure,
length change. So when you look at a muscle like piriformis, it is a long muscle, and it has substantial length change. So if it is frictioning the sciatic nerve, that could be a problem. Now, why would that be? Well, if you, I'm just giving some examples that
yes,
again the assessment would show. But if you were to watch a person and they had true piriformis now, so I'm not just talking about referred sciatic pain, and you saw the right knee buckle every time they ran, that buckling is load and friction
sure,
on the, so if you
okay,
said, all right, we could work on the mechanics, we could give you an orthotic on that side or something to try and see if we could change that mechanism. Is your pain gone? Well, some will say, a week, that piriformis syndrome is now gone. But I've seen it where I remember a high performance cyclist came, and it wasn't till I saw the MR. The sciatic nerve actually pierced right
I saw that
through the middle. Yeah,
before. Yeah,
it was an anatomic anomaly.
sure.
Now, what can you do there? Time off, let it
Oh,
settle,
yeah,
and I do think that for those kinds of things too, sometimes injections of certain
sure.
cocktails, if you go for someone who really knows the cocktails, can get
Sure.
the nerve to slide once again. But anyway, there's just a little bit of an opener
No,
on
that helps.
piriformis, but some people really have it and suffer,
Sure.
and others it's pure misdiagnosis.
Right. And that's what I suspected. My last question then, I just want to talk to you about the nerve flossing and how often do you incorporate it, and generally what circumstances do you see where you want to use nerve flossing,
Right.
the lower extremity?
Well, yes, there are. Well, first of all, there's a femoral nerve root and a sciatic nerve root that
Right.
goes to the lower extremity that are involved with radiating pain. When you do an assessment, let's just say you've flexed a person and they flex their head and they say, as I'm moving my head, I'm getting a radiating symptom to my, let's say it's my right great toe. So I've got a friction on the lumbar fifth nerve root. But then when I get there, the pain stops. So then I lay them prone over a table, and I will start to migrate the nerve back and forth. And it's only creating the symptoms as the nerve is moving. Then I'll maybe do some reflex testing. I'll change the curvature of the spine, change the shape of the canal and the foramens, and find, oh, there's no friction in that position, but there's friction in this position. What the Japanese showed a number of years ago is if you can get a nerve root to floss, it creates its own pathway. But we call it tickling the dragon's tail. As you know, in some cases of friction, you will create a raging fire in that nerve. So we then do some testing to see if this is, what's the chance of us really creating the lubrication, if you will, versus the friction. Well, we'll pull a leg from below with maybe a leg raise, and we'll have the head out over the end of the patient table, and they will extend at the same time. And we'll say, yeah, the nerve is moving well if your spine is in this position. And away we go. But again, it's assessment is king. It will show us. And I've also learned this. Sometimes I'm really surprised. We've had cases of arachnoiditis, so a little tether on a nerve root, usually post-surgical. And if they try certain movements, it creates a nerve tension and they get radiating symptoms. Just a little gentle pull every day, or their nerve flossing might be simply, let's go for a walk. Here's them going for a walk, and we'll say, get tall, swing your arms about the shoulders. And now, what a wonderful nerve floss that is. And, you know, I'm just thinking of this one patient where his heel was just on fire all the time. But after about 3 months of moving in this way to get the nerve to gently start to move, but not enough to trigger real symptoms, he said, I was dragging the garbage pail down the driveway to put out for the garbage collection. And he said, it just let go. And I felt a deep itch in my low back, symptoms in my heel left, just gone. And he still does nerve mobilization to this day. But there's
I just want to say you do cover that in the book a bit, some nerve flossing.
Yes, you know, I just read quite a nice book. I finished it last night actually, on adhesive arachnoiditis, and the clinician went into great detail on the various drug cocktails to try and get the nerve as lubricated as possible to let go and that kind of thing. Plus all the complications, you know, you run into people suffering with some of the collagen disorders, Ehlers-Danlos syndrome, and you know, hypermobility and things like that, which those people as a cluster tend to get more of these adhesions, and some of the cocktails they can take to reduce inflammation and that kind of thing. And then something else just popped into my head. I read a paper not too long ago on how strategic flossing really accelerates the clearing out of inflammatory soup post-injury or post-surgical as well. So, you know, we can go on for hours, all the combinations and permutations of when these things are effective and when they're poison. And
Well, the body just has amazing capacity to heal itself if you let it, or you put it in a position. It's just amazing to me.
That's the key.
Yeah.
That's the part that so many people struggle with.
Yeah.
How do we allow our body to regenerate instead of doing everything we do to make it degenerate?
Right. Absolutely. Absolutely. Well, again, I've held you way over time here, Dr. McGill. This has been such an honor and a pleasure. I'm going to replay this myself a couple times so I can listen to the answers, and it just, I still got more. I hope to maybe get you in the future again, but we'll have.
Well, we can do a little follow up sometime in the future.
Yeah, that'd be awesome. That'd be
Yeah,
awesome.
yeah.
So,
Well, I've enjoyed this, Bob.
likewise, great honor, great honor. So.